remembers that. May see it on a test question. Quiz. We don't take tests, we take quizzes. Okay, so the beta blockers. They play two roles. Number one, they decrease the neurohormonal stimulation. In other words, your adrenal glands are pumping out all the stuff that makes us anxious, excited, and when we get anxious and excited, our heart pumps faster a lot of times, but not necessarily more efficient. And if your heart is not functioning properly in terms of its musculature, then the faster it pumps may not necessarily be the better it pumps. So beta blockers, let's say Coreg and metoprolol, calm the heart by calming the beta adrenergic pathways. Now, they also seem to have an effect of increasing contractility of the heart, especially Coreg. So we'll often see it used. Both medications tend to be prescribed twice a day. Metoprolol comes in a tartrate and succinate. Tartrate is the most common. It's a twice daily medication. And then carvedilol is always a twice daily medication. Let's say we are using digoxin. Digoxin is usually administered with a loading dose and then a maintenance dose. And then, of course, you want to monitor that at least with every office visit. All of those medications are also pretty inexpensive for the patient, so it increases compliance when patients can afford their medicines. Big point. The next thing let's talk about is fluid offloading, removing the actual water in the blood that the heart's having to pump. So we've got this system of pipes connected to a pump. So we're thinking about plumbers like Mario and Luigi, if any of you even know what that is. There's too much water in the pipe for the pump. We want to poke a hole in it. So that's where diuretics come in. Now, in the next section, not on this section, the next part, when we talk about antihypertensives, we'll talk about diuretics such as hydrochlorothiazide. Do not use this for the treatment of heart failure. It is a very weak diuretic, and it's not indicated. So you hear of things like Lasix all the time. Everybody's on Lasix. It's a loop diuretic. Loop diuretics are the most potent. There's also Bumex, torsemide. They're all loop diuretics. They come in differing potencies. Now, another thing I know that you're all aware of with diuretics is the fact that they will cause you to pee out your potassium. So then we think of diuretics such as spironolactone, which are potassium sparing. And they definitely have their place, and they tend to work well in combination with another diuretic such as Lasix. Then there are other diuretics that work a little bit differently on the nephrons of the kidney, such as chlorthalidone. But right now, I want you to mainly think about the loop diuretics. These are what you're going to be using most. And we say loop, that's because they work on the section of the nephron called the loop of Henle. Just FYI, I know y'all know that. I'm not going to give you any anatomy questions. So we're removing the burden on the heart by removing the actual amount of water in the blood that has to be pumped. Diuretics. So we have beta blockers to relax the heart, to cool down the adrenergic effect and make it pump better. Two, we have diuretics. To help offload the work that the heart is having to do. Now, three, and this is important, are the angiotensin converting enzyme inhibitors. I had to think of what ACE stood for a second. Angiotensin converting enzyme inhibitors, such as lisinopril. We'll talk about that very basically. If it sounds like the month of April at the end, it's an ACE inhibitor. ACE inhibitors are very important for the purpose that they substantially reduce the amount of remodeling of the left ventricle. A lot of people start off with heart failure that's not as significant, but it will progress that way if not properly treated. Use of an ACE inhibitor is very helpful. It also may use it in patients with diabetes. It is very renoprotective in that it affects the aldosterone, angiotensin, the AA, RAS, renin, aldosterone, and I can't think of what the S stands for right now, the RAS, but you know what I'm talking about. Anyways, that's going to bug the crap out of me now. ACE inhibitors are important. So we're talking about three mainstays: beta blockers, diuretics, ACE inhibitors. Now, ACE inhibitors can be expanded to include angiotensin receptor blockers, ARBs. Basically do the same thing. Some of them work a little bit better in some cases. That depends. But for now, I want you to know that they're basically achieving the same goal, just in two different aspects. Now, when it comes to other things about lisinopril or ACE inhibitors for the use of blood pressure, we'll talk about that later. Right now, we're talking about ACE inhibitors strictly for remodeling of the left ventricles, prevention of it. Okay. Now, in the heart failure section, there's all kinds of things about adverse reactions. In fact, this is true of every medicine in the book. There's things about adverse reactions, the pharmacokinetics. When it comes to medications for the heart, there's one or two adverse reactions that you can always count on most of the time. Number one, every drug that prevents an arrhythmia causes an arrhythmia. And then a lot of them also can cause hypotension. So just bear that in mind. The next section talks about anti-arrhythmics. Sorry, it's been a very long week at the hospital. On page 91, there's table 6.1, which has a good breakdown of all the classes of antiarrhythmics. I don't expect you to remember every one of them. Let me tell you, class 1 has all of the oldest of antiarrhythmics. I don't see very many of them used anymore. On occasion, I'll see Tambacor or flecainide in people who have atrial fibrillation. The last time I ever saw lidocaine used, is in the hospital setting to terminate a ventricular arrhythmia. Probably not going to be putting people on lidocaine, so don't worry about that. Not that I don't want you to pay attention to the class 1s. Keep them in mind because when you're practicing, we're getting into a situation where there's a generation overlapping of very seasoned clinicians and then a bunch of very new clinicians. So we still get a mix of a lot of old medications that people they grew up with and that's what they use and they work. But now we have newer ones that may work better. So the ones that I really want you to focus on are the class 2, 3, and 4, the beta blockers, the potassium channel blockers, and the calcium channel blockers. Beta blockers, we just talked about them in heart failure. Metoprolol, Coreg, there are several, and they're listed on this chart. If it's got a LOL, L-O-L, laugh out loud, it means it's a beta blocker. I just came up with that connection. I'm sorry. Anyways, beta blockers slow the heart in the same manner that they work in heart failure. They work against the beta adrenergic system from the adrenals and reduce excitability. So let's say we have someone with a sinus tachycardia and it's persistent and their blood pressure is such that it could handle a beta blocker because that's another side effect of beta blockade and another use for it is management of hypertension. So we can kill two birds with one stone in a lot of situations with beta blockers. You can even manage atrial fibrillation with it. beta blockers. I've seen people manage quite effectively with metoprolol. This is an option I like to use depending on the clinical situation. If a patient cannot tolerate a calcium channel blocker, or if they have heart failure and cannot have a calcium channel blocker, beta blockers tend to be great. That's with a very simple case, and that's the way we'll leave it for now. Potassium channel blockers, they're a little more complex. These are used primarily for the termination or management of atrial fibrillation. When I say termination,